So that's a really important point about CNS relapse. So CNS relapse back, if you go back 30, 40 years, was a major problem. And when you had the introduction of intrathecal therapy, the risk of CNS relapse dropped dramatically and became much less important numerically than bone marrow relapse. But with the advent of Blinatumomab, the risk of bone marrow relapse is decreasing because, of course, that's where the action takes place. But, of course, Blinatumomab doesn't cross the blood-brain barrier, so it doesn't decrease your risk of CNS relapse. So one of the challenges facing clinical or protocol designers is how much therapy do you give to prevent CNS relapse in the Blinatumomab era. And what we were able to do is look at 2 consecutive trials in the UK to identify risk factors that were specific for CNS relapse. Now, some of those risk factors are also risk factors for bone marrow relapse, and that's not necessarily a major surprise. But what we were able to do is develop a model that is based on genetics, age, white cell count, that can accurately predict patients that are at a very high risk of CNS relapse, and this is a CNS relapse of about 15% at 5 years, which is very high, and also a group of patients have a very low risk of relapse, like less than 1%. So that kind of model may help clinicians design treatment protocols with Blinatumomab and the appropriate amount of CNS-directed therapy.